This is a general disclaimer. Redlands Community College attempts to have the most accurate and up-to-date information listed in its content and delivery. However, your education is your responsibility. Redlands Community College or Roy Smith makes no guarantee in the accuracy of this information in this video and accepts no liability for the informational video. The information expressed is strictly the opinion of the author and the presenter, which is listed in the reference near the end of the video. This information is designed to supplement your own education or initial education and should not be used to replace any current academic program you're enrolled in. View the information and content at your own risk. Thank you. This is going to be Chapter 11, Disorders of Cerebral Circulation. Key concepts. Upon completion of this chapter, you'll understand how headache, weakness, and other mental and physical abnormalities can be related to a stroke, but may also be caused by conditions that are treatable and reversible in the field, things like hypoglycemia, hypotension. That strokes may occur in patients in any age, from the newly born to the elderly. How symptoms of strokes are related to the location of injury and any related inflammation or edema that might occur. And that most treatments for disorders of cerebral circulation are time-dependent. That would be less than 3 hours. We're going to harp on that a lot. Chief concern, stroke. It's a devastating disease, the third leading cause of U.S. death, leading cause of disability. Numbers expect to double in the next 20 years. Costs between $43 billion and $51 billion annually. Differential diagnosis for a stroke, things like hypoxia, hypoglycemia, hyperglycemia, hypotension, and hypertensive emergency, all will adjust how a person's mental status will be presented. Not enough oxygen, not enough glucose, too much glucose like DKA, hypotension, not enough blood pressure to perfuse their head, and then hypertensive emergency, too much pressure still doesn't allow for adequate perfusion of the cerebral tissues as well. Space-occupying CNS lesions, things like a tumor or subdural bleeds, are also kind of devastating, will alter mental status. Infections like herpes, encephalitis, meningitis, or poisonings of any sort. Uremia, toxicology, toxic syndromes are where they are have overdosed on a drug or several drugs. Headaches, migraine mimicking strokes. Psychiatric disorders, converse disorder, or functional hemiparesis. So all of these may be mimicking strokes. However, finding the clinical indication without, especially from the field position as a paramedic, we don't have a CAT scan in the back of our truck. We can't tell if they're at toxic levels. We can't tell if their sodium is out of whack. So things like this will have to be reassessed later on whenever they get to a facility that can do these kind of things. Stroke is an interruption of the blood flow of the brain, resulting in the loss of function. Important concepts on this is going to be the cerebral physiology. The brain consumes a lot of oxygen and cardiac output, 15 and 20% of the cardiac output, and 30% of the blood glucose, and as much as 50% of oxygen at rest. Circle of Willis kind of helps us with that. The circle of Willis is a circular artery that essentially allows for collateral circulation in the brain. Pathophysiology of the stroke, we can have a cardiac embolus, which under a heart attack, low perfusion from the heart, allows for a clot to form, and then if we shoot that up into the brain, very easily be a stroke. Acute myocardial infarctions, like weakness of the ventricular wall, development of an aneurysm. Endocarditis and stroke, inflammation of the heart's most inner lining. Turbulence gives a potential for thrombus formation. Arterial embolism, any aortic outflow obstruction can lead to the development of a thromboembolism. Hypertrophic cardiomyopathy, carotid artery disease, atherosclerosis. A carotid endarterectomy clears the interior walls of the carotid of any kind of plaques that might be developing in there. Vertebral embolisms are also a concern. Whenever the vertebral arteries are occluded, it results in an infarction of the brainstem. Now, one of the signs and symptoms that we see in brainstem infarctions is vertigo. Feeling of things spinning around, common symptoms in a brainstem stroke. Locked-in syndrome can also occur. Patient with an acute intact brain that is housed inside a body that is completely paralyzed. All kinds of different pathophysiology for strokes. Ischemic strokes.
Ischemic strokes include thrombotic strokes, lunar strokes, lacunar strokes, microocclusion of the small vessels can result in microscopic areas of ischemia at the terminus of the arteriole. Watershed strokes, direct results of hypoxia, hypoglycemia, or hypoperfusion. They occur due to the absence of oxygen, glucose, or blood flow. Important concepts of this are going to be neurophysiological changes of an ischemic stroke, and that is, following an ischemic stroke, chemical changes occur within the brain. The tissue, as it progresses from ischemia to injury to infarction, neurochemical releases from the stroke cause further damage. So it's like putting gasoline on a bonfire. It's going to get bigger and bigger and bigger. We have to get ahead of the physiology. Increase the oxygen, get them to a place that can fix the aneurysm, fix the bleed, take care of the thrombus that's in there. Prognosis and mortality completely are dependent on a number of factors. Premorbid factors, vessel involvement, how big it was and how much supply did it give to the brain, severity of the actual stroke that occurred, and then the post-stroke complications, and that would be probably from the damage. Hemorrhagic strokes, arteriovenous malformations. Now, it's congenital abnormalities that appear like a tangled bundle of blood vessels. Now, any of these arteriovenous malformations can cause an aneurysm, which could cause an internal bleed inside your head. Subarachnoid hemorrhage, arteriovenous malformation, or intracerebral aneurysm, ruptures and bleeds into the subarachnoid space. Interparenchymal bleeding directly into the brain tissue itself. So this is in all the nooks and crannies. And then we have neurophysiological changes. Hematomas act like a space-occupying lesion. Now, what that means is as that hematoma increases, it's going to apply more pressure intracranially. It exerts pressure onto the adjunct delicate brain tissues, crushing those tissues as well as compressing adjunct structures. Intracranial pressure rises, and the cranial nerves exiting from the base of the skull are compressed. Cushing's triad is an outcome of this. Rising blood pressure or hypertensive, decreased heart rate or bradycardia, and abnormal respiratory patterns. So we should always watch for that if we think that we have developing intracranial pressure. Pediatric strokes. Strokes can strike anyone at any age. Congenital cardiac abnormalities from intrauterine infections, sickle cell disease, congenital arteriovenous malformations, children and young adults, the higher incidence of trauma-related injuries. So in children and young adults, the primary cause of the strokes or the head bleeds or the hemorrhagic strokes are generally from trauma-related injuries. Mimics of a stroke, things like Bell's palsy, seizures, thoracic outlet syndrome. So in Bell's palsy is the seventh cranial nerve that becomes inflamed, secondary to like Lyme's disease or herpes simplex, and then nerve palsy develops. So we can get a facial droop off of that. In seizures, about 13% of the patients with generalized seizures will have unilateral weakness during the postictal period, and this is called Todd's paralysis. Thoracic outlet syndrome, a group of disorders which affect both nerves, causing neurological deficits as well as effects upon the blood vessels. And this is figure 11.7 of Bell's palsy in your book. History. Important points. With stroke symptoms, did they have a headache, numbness, weakness? Are they more clumsy than usual? The OPQRST mnemonic, chief concerns, activity at the time of onset, symptoms, and the quality of the symptoms, medications that they're on, impairment, severity on a scale of 1 to 10, or gauge that for them due to the weakness. If the more information we get from them, the better. Exact time of onset. A past stroke is an indicator for future strokes, and we should elicit a careful history. So this is table 11.4, effects of a stroke. On a right-sided stroke, we can have paralysis on the contralateral side. So if it's on the right side, then we're going to have paralysis on the left. Paresthesia on the left as well, and contralateral side, loss of left lateral gaze, excessive talking, slurred monotone speech, difficulty swallowing, difficulty recognizing familiar faces, and short attention span. Left-sided strokes, we see paralysis on contralateral side, on the right side, and paresthesia on the contralateral side, or the right side. The loss of right lateral gaze, difficulty speaking, inability to read or write, difficulty with purposeful movements. Brainstem strokes, we see double vision, loss of sensation to the face, unilateral dilated pupils, difficulty swallowing, loss of fine motor control. Cerebral strokes, ataxia or drunken staggers, slurred speech, tremors, and abnormal eye movements or nystagmus. On examination, important concepts. We should focus on the primary assessment, and the areas of focus should be their airway, their respirations, their respiratory pattern, hypoxia presence, and baseline vital signs. And that would include blood glucose. Major areas identifying potential mimics of stroke and assessing the severity of the neurological deficits following the stroke. And last but not least, identifying any comorbid illness that might complicate the condition. Example, congestive heart failure, recent heart attack, and so on. Vectored physical examination. Area of focus should be trauma and cardiovascular, and these both should be used to rule out the stroke. And we have several stroke scales that are in place that we can look at. The Cincinnati Stroke Scale, which essentially looks at 3 criteria: facial symmetry for facial droop, extremity weakness, and this would be a pronated drift, palms up, eyes closed to see if they have weakness in one of the arms, and then slurring of the speech. The Los Angeles Stroke Scale includes all of that in the Cincinnati, plus includes time of onset of symptoms and point-of-care blood glucose testing. The Miami Emergency Neurological Deficit, or MEND exam, includes a quick assessment of the mental status, cranial nerves, extremities, and prompts for treatment, and an abridged fibrinolytic checklist. So they step above a little bit and start a fibrinolytic checklist in case they meet the criteria, that they can assist the facility on the other end. The National Institutes of Health Stroke Scale looks at several things. Level of consciousness, to where they are alert, they respond to voice, pain, or they're unresponsive. Visual fields and cardinal gazes, and then they assess for deficits. Hominis, hemianopia, the loss of the same half of a visual field in both eyes. Diplopia, double vision. Agnosia, meaning without knowledge. Prosopagnosia, inability to recognize familiar faces. Facial palsy, facial droop, inability to close eyelids, and excessive tearing. Speech anaphasia. Aphasia is the inability to comprehend or utter speech. Expressive aphasia, and this is Broca's aphasia, inability to communicate. Receptive aphasia, or Wernicke's aphasia, inability to comprehend the spoken word. Global aphasia occurs when a patient's stroke involving more global aspects of the cerebral cortex impairs the ability to both comprehend and to respond to conversation. Motor and cerebral function, we get monoparesis, weakness of just one limb. Quadriparesis, weakness in all 4 extremities. Hemiparesis, weakness in one side of the body. Ataxia, slurred speech, a loss of balance, and a staggering gait. Nystagmus, flickering extraocular movement observed when assessing the cardinal gazes. A Romberg's test, which we don't do much in EMS. Classic cerebral test, tests the ability to stand in a steady upright position with the eyes closed. Higher cortical functions. Apraxia, inability to carry out simple or learned purposeful movements. Sensory loss, paresthesia, the loss of feeling. Stroke and evolution. Diachesis or neural shock, sudden loss of function in an area connected by neuronal pathways, not directly adjunct to the ischemic area. It's due to edema and inflammation of ischemic tissue, may resolve itself spontaneously, and is generally caused from edema and inflammation which subsides. That's why it resolves all by itself. Assessment based on presenting symptom pattern may postulate that the patient is having an ischemic stroke or may suggest that the patient is having an ischemic stroke. Must limit pre-hospital diagnosis to a disorder of cerebral circulation, and further testing is required. That's because we don't have CAT scans in the back of the truck, we don't have full labs, so get them to a facility that can assist them. Treatment considerations of the obtunded patient of a Glasgow coma scale less than 8, we should consider that to possibly protect the airway, if we cannot control it under BLS means, we should facilitate an intubation. Consider lidocaine administration in this. Lidocaine is neuroprotective because of its sodium channel blocking properties. Assess their ventilation and respiratory effort. In hemorrhagic stroke treatment, treat for traumatic brain injury. Controlled hyperventilation is utilized only if necessary. Make efforts to control hyperthermia and then maintain their core temperature. Glycemic control should be initiated on all of these patients. Glucose should be minimally at 80 to 100 milligrams per deciliter with a goal of maintaining the patient's normal blood glucose state. Glucose-containing intravenous solutions should be avoided. Prophylactic seizure control is not indicated. If the patient does have a seizure, though, benzodiazepines would be the drug of choice. That would be things like Versed, Valium, or Ativan. Hypertension treatment, a systolic blood pressure greater than 170 or a diastolic blood pressure greater than 100, we generally try to reduce this. Beta blockers are the drug of choice. They do have IV versions of this as well, like labetalol. Paramedicine in the future, we may see very early treatments of some things that are currently being assessed as far as evidence-based medicine. Early administration of neuroprotective agents, magnesium, glucose, insulin, potassium, and so on. Evaluation of transient ischemic attack, or TIA. It's a temporary cessation of blood flow in the brain. Leads to temporary focal neurological deficit, generally lasts only a few minutes. Reassess the patient for seizure possibility, factors suggesting stroke development if they're greater than 60 years old, initial presentation with hemiparesis or aphasia, especially if the symptoms lasted over an hour or there's a history of hypertension or diabetes in their background. We should always err in the favor of the patient. Disposition, the National Institute of Neurological Disorders stroke trial demonstrated that TPA, or tissue plasminogen activator, was an effective treatment option for ischemic strokes if the patient received the treatment within 3 hours of symptom onset. Rapid transport. The brain damage can be prevented as much as 50% of cases under certain conditions. Futures in stroke care, expanding new technologies to include probably induced hypothermia, hyperbaric chambers, and stem cell research in stem cells. Conclusion. Signs and symptoms of a stroke. They vary based on the territory that the actual brain is damaged. Patients who have a TIA that resolves are at a higher risk for having a massive stroke. The paramedic needs to constantly reevaluate the situation and constantly reevaluate the patient. References for this chapter were taken from Professional Paramedic Volume 2, Medical Emergencies of Del Mar Learning. And if you have any questions, feel free to contact me. My name is Roy Smith, roy.smith@redlandcc.edu or 405-219-7613. Thank you.